Welcome, everyone. Today, we'll dive into how the liver tells its story through lab values. As MLS students, you're the detectives, and clinical indicators are your clues to uncovering what's happening inside this remarkable organ. Think of the liver as the body's chemical factory. It processes nutrients, filters toxins, and keeps our metabolism running smoothly. When it's injured, these functions get disrupted, and those disruptions show up in the lab. Before we jump into diseases, let's recall the main lab markers. Each test tells a piece of the puzzle. Some reflect hepatocellular damage, others biliary obstruction, and a few show synthetic function. ALT and AST are our frontline enzymes. When hepatocytes rupture, these enzymes spill into the blood. ALT is more liver-specific, while AST can come from muscle or heart. So always consider the ratio. It's diagnostic gold. ALP loves bile ducts. If bile flow is blocked, ALP climbs. But ALP alone isn't enough. GGT helps confirm it's hepatic. If GGT is also elevated, you're looking at a cholestatic pattern. Bilirubin is the breakdown product of heme. The liver conjugates it for excretion. So knowing whether it's conjugated or unconjugated tells you where the problem lies, before, within, or after the liver. These two markers show the liver's synthetic capacity. Albumin reflects long-term function, while PT responds quickly to acute declines, like in fulminant hepatitis. Recognizing the pattern is half the diagnosis. Each enzyme rise hints at the type of injury occurring in the liver. In acute hepatitis, hepatocytes burst open. ALT skyrockets, sometimes into the thousands. If PT starts to prolong, that's a red flag for hepatic failure. Chronic hepatitis tells a slower story. The enzymes fluctuate, and albumin begins to fall as fibrosis sets in. In alcoholic liver disease, AST dominates because alcohol damages mitochondria. GGT also spikes. It's both a liver enzyme and a drinker's signature. NAFLD is metabolic, often linked to obesity and insulin resistance. The enzyme pattern looks mild, but don't be fooled. It can quietly progress to serious scarring. By the time cirrhosis develops, the liver's enzyme-producing cells are mostly replaced by scar tissue. That's why enzymes may normalize, even as function declines. Cholestasis is all about backup. Bile can't flow properly. Whether it's from stones or drug reactions, ALP and GGT will soar. When stones block bile ducts, you'll see a cholestatic spike. Once the obstruction's relieved, levels often normalize fast. In HCC, enzymes vary, but AFP stands out as the tumor marker. Always monitor AFP trends in cirrhotic patients. Drugs can mimic almost any liver pattern. Acetaminophen causes massive hepatocellular necrosis, while others produce cholestasis. In newborns, the conjugation machinery isn't mature yet. Unconjugated bilirubin builds up. It's usually benign, but needs monitoring to prevent kernicterus. Lab results alone don't diagnose, they guide. This stepwise approach ensures you interpret the data in context. Remember, enzymes are clues, not verdicts. As MLS professionals, your interpretation helps physicians pinpoint the underlying disease and guide treatment.